Hello, I'm Dr. Tharka Maurya, urologist at Akkineni Hospitals. Hope you are well. In this session, we'll cover key information. Stay with us and jot it down.
Hey everyone, and welcome to today's Explainer. I'm so glad you're here because today we're diving headfirst into what's basically a medical detective story. We're tackling a topic that's, well, frankly, been wrapped up in outdated myths, social stigma, and way too much silence. Yep, we're talking about male infertility. For way too long, the heavy lifting of fertility struggles has been pushed onto just one side of the equation, right? But today, we're throwing out those old societal myths, bringing in the hard science, and getting you some clear, actionable knowledge. We're going to see exactly how modern urology is cracking these cases wide open. So let's just get right into it. Okay, here's our quick roadmap for today. We'll start with the overlooked half, then break down the semen analysis, and decode some of that crazy medical jargon. After that, we'll hit causes and treatments, give you a really crucial testosterone warning, and wrap it all up with the concurrent approach.
All right, section 1, the overlooked half.
So right off the bat, we need to challenge a massive, completely unfair assumption. Historically, the pressure of fertility struggles has fallen almost entirely on women. But the actual data, it totally shatters that myth. Get this, male factors are actually responsible for 40 to 50% of all infertility cases, almost half. It's a shared biological equation, and the male factor is a massive, completely equal piece of the whole puzzle. And honestly, that's exactly why this societal myth is just so dangerous, because of all that intense social pressure placed on women, and we see this especially in regions like India, checking the male partner gets pushed way down the line. And we aren't just talking about waiting a few weeks here, we're talking about delays of months or literally even years. And the result? Well, that delay drastically reduces a couple's overall chances of actually conceiving. Waiting around to check the guy's half of the equation just burns through precious time that could be used on some seriously effective treatments.
Moving on to section 2, the semen analysis.
So, if we're treating this like a medical investigation, we've got to have our starting evidence, right? The clinical baseline comes directly from the World Health Organization's 2021 reference values. Let's break it down real quick. For volume, urologists are looking for 1.4 milliliters or more. For concentration, you want at least 16 million sperm per milliliter. Total motility, which is basically just how they move, should be sitting at least 42%, with progressive, forward-swimming motility hitting 30% or higher. And finally, morphology. That's the shape. That needs to be at least 4% normal. If these numbers are off, boom, the urologist knows exactly where to start looking next. Which brings us to section 3, decoding the jargon. When a patient gets that lab report back, it's usually crammed with these terrifying multi-syllable Latin words. Let's just take a breath and translate them into plain English. First up is oligozoospermia. Oligo just means few, so this literally translates to a low sperm count. It means the concentration is dipping below that 16 million per milliliter threshold we just talked about. Nothing more, nothing less. Next on the list is Azoospermia. This one is all about movement. If you see this on a chart, it just means the sperm have poor motility. They might be a bit sluggish, or they just aren't swimming in that nice progressive forward direction they need to actually reach their destination. Then we've got Teratosospermia. Now, this is all about architecture. It means abnormal morphology. In other words, there's a hiccup with the shape and normal form of the sperm. The sperm might have a misshaped head or tail, and that just makes it a whole lot harder for them to penetrate an egg. Now, sometimes these individual terms gang up to form something called OAT syndrome. That stands for oligoasthenoteratozoospermia. Wow, okay, I know that sounds incredibly overwhelming to read on your test results. But here's the real deal. It is simply a combination of those three exact things: low count, poor movement, and abnormal shape, and more importantly, this is actually the single most common clinical pattern urologists see. So if you have this, you aren't some strange anomaly, you're exactly the kind of patient urologists successfully treat every single day. And finally, there's Azoospermia. This means there is a total absence of sperm in the ejaculate, literally zero. That is an extreme baseline, and obviously it can be pretty devastating news to receive. But as we're about to see, a zero count absolutely does not mean a 0% chance of fatherhood. Actually, finding this out perfectly sets the stage to hunt down the physical culprits and, more importantly, their cures. All right, section 4, causes and treatments. Let's find some solutions. This is where our story shifts from simply diagnosing the problem to actual real-world optimism. We're going to look at what physically goes wrong under the hood, and we're kicking it off with a massive success rate, 60 to 70%. That number is tied to something called a varicocele. Basically, these are dilated, enlarged veins in the scrotum. It kind of acts like a broken radiator, raising the testicular temperature and messing up sperm production. Believe it or not, it's the absolute most common reversible cause of male infertility. The fix? A precision microsurgical varicocelectomy, and it improves those sperm parameters in 60 to 70% of patients.
Now, let's loop back to azoospermia, that really scary term meaning zero sperm. There are two very distinct types here, and they mean completely different things. First, you have obstructive azoospermia. Think of this as a plumbing issue. The factory is making sperm just fine, but there's a physical blockage in the pipes. Surgeons can literally just bypass the block and retrieve the sperm using techniques like PESA or TESA. On the flip side, you have non-obstructive azoospermia. This one is a factory issue. The production itself is impaired. But even here, guys, hope is not lost. Using a highly advanced procedure called a Micro-TESE, surgeons can successfully find and extract usable sperm in about 50% of these cases.
And the urological toolkit doesn't stop there. It fixes some pretty fascinating, time-sensitive structural issues too. Take cryptorchidism, for example. That's an undescended testicle. The huge takeaway here is the ticking clock. It really needs to be surgically corrected before 18 months of age or by age 2 at the absolute latest. Otherwise, you risk irreversible damage to sperm production. Oh, and here's another incredible fix: retrograde ejaculation. This is a condition, usually caused by diabetes or spinal injuries, where the semen actually flows backward into the bladder instead of going out. The solution? Get this. Urologists can actually retrieve perfectly healthy sperm straight from the patient's post-ejaculatory urine and use it for fertility treatments. Talk about medical ingenuity, right? Of course, if it's not a structural plumbing issue, the urologist has a whole suite of other detective tools ready to go. They'll run a hormonal profile, checking out things like FSH, LH, and prolactin. They can also deploy advanced genetic testing. They might check for a Klinefelter syndrome karyotype or Y chromosome microdeletions, which, by the way, is absolutely crucial to check before even attempting a Micro-TESE surgery. They'll use scrotal and transrectal ultrasounds to visually hunt down any hidden blockages. They can even test for sperm DNA fragmentation to see if there's oxidative stress happening. Basically, they leave absolutely no stone unturned.
Okay, Section 5, the testosterone warning.
Guys, I need you to pay really close attention right now, because this is a totally counterintuitive medical reality. While having low testosterone, hypogonadism, is highly treatable, you have got to be incredibly careful with testosterone replacement therapy. Taking exogenous or outside testosterone, it actually acts as a male contraceptive, no joke. It tricks the brain into shutting down its own biological signal to produce sperm. So the golden rule here is simple. Exogenous testosterone should never be used by a man who is actively trying to father a child, period. Which leads us perfectly into Section 6, the concurrent approach. So after seeing all these amazing diagnostics and structural cures, I think we seriously need to redefine how couples tackle their fertility journey. I want to leave you pondering this. Why on earth would anyone wait months or even years to evaluate exactly half the biological equation? Since a massive portion of these male issues are entirely surgically reversible, delaying the guy's evaluation just puts couples through so much unnecessary emotional and financial strain. It just doesn't make sense. And that brings us to the ultimate conclusion. Fully backed by the expert andrology and urology team at Akkineni Hospitals, the core takeaway is just this. Urological evaluation absolutely must run concurrently with the female fertility workup right from day one. It should never, ever be an afterthought. Looking at both partners from the absolute get-go is the true key to optimizing your chances of a successful pregnancy. So if you, or maybe someone you know, is starting out on this journey, you've got to ask, are both halves of the equation being empowered by science from the very start? Thank you so much for hanging out with me on this explainer today, and hey, keep asking the right questions.